Welcome to AETCM, the Emergency Medicine Channel. Shall we start? A 52-year-old male patient presented to the ER, which was referred from other hospital with history of complaints of fever with chills for the past 5 days with cough with purulent sputum and shortness of breath. On initial 10-second assessment, airway is patent, no pooling of secretions. Coming to breathing, respiratory rate is 32 per minute with saturation 84% in room air. Chest has bilateral coarse crepitations with a reduced air entry in the basal side. At that time, we initiated O2 support.
What is the respiratory rate?
Rate is 32 per minute. So that we initiated O2 support on face mask with 8 liter O2, which shows 92% in 8 liter O2. And coming to circulation, patient has 160 BP with a heart rate of 112 per minute with peripheral pulses are equally palpable. Disability GCS is 15 by 15, GRBS is 280, pupils bilaterally equal, exposure 100 degree Fahrenheit temperature. We put IV cannula and give one injection paracetamol.
So here we have a patient who has presented with complaints of fever and cough, and patient is in respiratory distress. Okay.
And we took one CBC CRP point of care which shows HB of 11.2 and total count of 17,800 and with the neutrophil predominance of 88% and lymphocyte 8 and platelet count of 1,20,000 with CRP 156. And we also took one ABG at that time which shows pH of 7.31.
Is the patient in shock? What is the heart rate?
Heart rate is 112.
112. So that is on the higher side. Even though BP is not
160.
low, 160, heart rate is on the higher side. So here the counts are elevated.
Counts are elevated and temperature is also there. Temperature is also there.
Temperature is also there.
And in ABG was pH is 7.31 with the bicarb 22 and PaCO2 is 48 and PO2 is 62. And
this was ABG, not VBG.
ABG. And lactate is 3.2. And saturation is 88 at the time. And when we calculate the PO2 by FaO2, that is 103 at that time. And we done the further chest X-ray was done, which shows bilateral diffuse alveolar infiltrates also. And ECG shows sinus tachycardia only. And we done one screening echo at that point of time, that is normal LV function with ejection fraction of 60%, no cardiogenic causes at that time.
So and so patient comes with fever, cough, breathing distress. A patient is having a tachycardia with the fever, and our point of care shows increased CRP and CBC is also increased. Patient is having fever. So what will be a differentials that comes to your mind? Is the patient having any history? He's coming from an outside hospital, no?
Already admitted in the outside hospital.
So was there any diagnosis made in the outside hospital?
They treated it as a LRTA.
LRTA.
Lower respiratory tract
So we have a patient who is referred from other hospital with an underlying LRTA presenting with these many complaints. So what will be a differentials? What do you think this patient might be having after the primary survey and the adjuncts?
Patient basically has an LRTA, pneumonia picture is there, and which is progressively worsening the shortness of breath and also that will lead into a diagnosis of acute respiratory distress
syndrome. So what is ARDS? Why do you call this as ARDS?
There is progressive worsening of the dyspnea and also there is no other cause for this progressive pleural effusion or cardiogenic pulmonary edema.
So how do you define an ARDS? What is ARDS? ARDS is an inflammatory lung injury and there is a Berlin's criteria for ARDS. What is that? Berlin's criteria was initially put forward in the year 2012. But recently in 2022, they made few changes to Berlin's criteria. So what are the Berlin's criteria? What is the first thing that you see in a Berlin's criteria? It is for diagnosis of ARDS. So what are the things in Berlin's criteria?
That the symptoms begin within the 1 week of the insult, or there is new symptoms or worsening of the symptoms.
That
in the
is
last
first
one.
thing. New or worsening
Worsening of
symptoms
symptoms.
in the 7 days. That is first. Second.
There will be bilateral opacities in the chest X-ray, and when we calculate the PO2 by FiO2, that should be less than or equal to 300.
No, that is the third point. Second point is there has to be. No, that is also next. There are few points in Berlin's criteria. First is new or worsening respiratory distress. That is in the last 7 days. And second thing is patient should have bilateral infiltrates in the chest X-ray and also in the CT. And there is another thing that added in the 2022 Berlin's is ultrasound. If there are features of ARDS in an ultrasound done by a trained professional, excluding the fact that these infiltrates should not be nodules, mass, any atheletasis or any pleural effusions. Other than this, it has to be there. Next is severity of hypoxemia. For severity of hypoxemia, if a patient is coming to ER, patient is on oxygen, this patient was on face mask oxygen, can you calculate PF ratio in such a patient? You can't calculate. PF ratio can be calculated when there is a positive pressure that you give. Either an intubated patient or a non-intubated patient on HFNO or NIV. So you can't the correct, because there has to be a minimum PEEP for us to calculate the PF ratio. So severity of hypoxemia can be mild, moderate and severe based on the PF ratio. That is PaO2 by FiO2 ratio. For a patient who is non-intubated, PF ratio less than 300 suggests ARDS. For a patient who is intubated, mild is PF ratio less than 300. That is more than 200 to less than 300 is mild. More than 100 and less than 200 is moderate. And these all has to be in a PEEP of 5. Minimum PEEP of 5. And mild can also be seen in can be calculated if the patient is in HFNO. HFNO at a rate of 30 liter per minute, if the oxygen is going, you can calculate the mild one. And moderate severe is less than 100. And there is another thing called saturation saturation SpO2 FiO2 ratio. What is that?
That is if it is less than 315 mm of Hg on HFNC via nasal cannula, if it is more than 3 liter per minute. And also
not nasal cannula, HFNO.
HFNC. And in NIV, CPAP more than 5 cm of H2 of end expiratory pressure.
And in intubated patient also there is a difference. Mild can be SpO2 by FiO2 ratio less than 315, provided the saturation is less than or equal to 97%. In moderate, it is 235. And in severe, it is 148, less than or equal to 148. So with these two ratios, you can calculate the severity of hypoxemia. Then what is the next point? That this should not be explained, this respiratory failure should not be explained by an underlying cardiogenic pulmonary edema. So these are the points in Berlin's criteria which help us to diagnose ARDS. So what is, so this patient had an underlying LRTA. What are the things that can cause an ARDS? ARDS is an inflammatory lung injury which is very progressing. So what are the things that can cause ARDS?
Causes of ARDS, like if it is patient pneumonia history or sepsis.
So basically you can divide it into two. There is an extra pulmonary cause and a pulmonary cause. Extra pulmonary causes are also known as indirect lung injuries, and pulmonary causes are direct lung injuries. Indirect lung injuries are like
Burns, pancreatitis.
Burns, pancreatitis, any other sepsis anywhere else other than the lungs. Or it can be things like transfusion associated lung injury, ischemic reperfusion injury, neurogenic causes. These are all extra pulmonary. What is pulmonary? That is direct lung injury. What are those?
Pneumonia,
a ventilator associated lung injury, any smoke inhalation, inhalational injury, aspiration pneumonia, drowning, these and all causing ARDS are the direct lung injuries. So that are the causes of ARDS. Now if a patient presents to you with ARDS, what are the things that you should consider? Differentials, what will be your differentials?
Pulmonary edema, no.
Pulmonary edema. Main differential is pulmonary edema. So what are the difference between a patient presenting with ARDS and a pulmonary edema? What are the, like in clinical signs, what will be the difference in both?
In cardiogenic pulmonary edema, there will be features of heart failure.
Patient will be having, either he will be having history of heart failure, patient will be having elevated JVP, there will be an S3 gallop, and in these signs, orthopnea will be there, PND history will be there. In the other side, there will be some precipitating factor will be there in case of ARDS, whereas patient will not be having all these features of heart failure. And what about X-ray? What is difference in X-ray? If you take a bedside chest X-ray, what are the features that tell you that patient is having a heart failure rather than a patient is having ARDS? In ARDS, we already said diffuse lung infiltrates. These infiltrates has to be either fine granular or ground glass opacities, excluding what I told you, nodules, masses, any collapse, atheletasis, and not a pleural effusion also. Whereas in cardiac, in case of heart failure, there will be curly V lines, pleural effusion, patient will have cardiomegaly, and all those features will be there. Now, there are investigations that can distinguish between an ARDS and a pulmonary edema. Cardiogenic pulmonary edema, what are those? NT-proBNP is something that we do. Other than NT-proBNP, there is something called pulmonary artery wedge pressure. So this pressure, if it is less than or equal to 18 mmHg, this is more likely to be an ARDS. And there is something that you do in BAL. What is lavage? You do something. What is that? In something that you get in ARDS. The patient will be, after doing BAL, will get that aspirate, no? You check the neutrophil count. In normal, if the patient is not having an ARDS, patient's neutrophil count will be less than 5. But in a patient who is having ARDS, out of the cells, more than 80% cells will be neutrophils. So that is one thing. Second thing is, you can get a ratio of proteins present in the plasma, in the aspirate, divided by plasma protein ratio. You can check. This is basically a proteinaceous infiltrates, no? So the ratio will be more than 0.7 if it is an ARDS, and it is less than 0.5 in case of heart failure. What exactly in a pathological level happens in ARDS? There are few phases of ARDS. You know the phases? Like there is an exudative phase, then there is a proliferative phase, and there is a fibrotic phase. So initially, when there is any inflammatory lung injury, there will be pneumocytes, type 1 pneumocytes, and the alveolar capillary endothelial cells will be damaged. So there is an alveolar barrier which is being damaged. So all these fluids and proteins, macromolecules all infuse into the alveoli. That happens initially. And then when it comes to proliferative phase, what happens is these proteins will line up the alveoli. It will form a membrane. That's why I used to call it a hyaline membrane disease. So these and all happens in the exudative phase. And it is mainly of neutrophil predominant state. That happens in the first 7 days. So once it comes to the proliferative phase, these neutrophils will be replaced by lymphocytes, and the type 1 pneumocytes are destroyed. So the type 2 pneumocytes will start to proliferate, and early changes of fibrosis will start. And when it comes to fibrotic phase, final phase, there will be extensive fibrosis. And that is what is happening in an ARDS. That is the pathological picture, because of which we get all these changes in that investigations that I told you, and all are based on this. So we told what are the causes, how to basically differentiate. Need not be heart failure, any patient with an ILD, all these differentials can mimic an ARDS. Now, if a patient comes like this, what are the investigations that we should send for this patient? Like you have to send blood investigations, we have to do a chest X-ray, and all these investigations, in this case we know it's an LRTA, but in cases which is directly coming to the hospital, we have to check the infection markers, where is the infection, what are the sources. You have to look for other sources if it is not lung, like if it is a pancreatitis causing an ARDS. So all that evaluation has to be done, along with which you have to do an NT-proBNP in case you suspect an ARDS. So these are the investigations. So after investigations, how to manage a case of ARDS? What do we do in ARDS? ARDS is an inflammatory pathology of a lung. So anything that we do is not to suppress the ARDS. We are just like supporting the lungs so that the lungs take the time to heal by itself. So what is the first thing? So mainly ARDS treatment will be symptomatic management and treat the cause. What is the cause has to be treated, otherwise ARDS won't resolve. And what as emergency physicians we should do, we have to support, give the symptomatic supportive management. So what comes in that first? First is airway. So airway, patient is having respiratory distress. Here what did we do to the patient? Patient was on respiratory distress. Patient was maintaining at 8 liter O2 he was maintaining, no?
92.
So what did we do? What can we do in a patient with ARDS? In case of airway, you have to support airway. Either you can use an HFNO, you can use an NIV, or you can use a vent. You can intubate the patient and put on mechanical ventilation. All these will give a support to the lungs so that the lungs will heal by itself. So what is an HFNO? In HFNO, you give heated humidified oxygen. Heated doesn't mean very high temperature. It is only 31 to 37 degrees Celsius. Heated humidified oxygen is passed through at a rate of 30 to 60 liter per minute. So what this will do is it will give an a peep. It need not be 5 and all, but it will give a peep of 2 to 3. So this will recruit the alveoli which is already filled with fluid. So more and more alveoli will take part in this breathing and ventilation. So either you can use an HFNO, or if not, you can put the patient on NIV. These are all positive pressures you are giving. So the PF ratio you calculate only if the patients are in all these positive pressures. But if the patient is not maintaining or saturation, even irrespective of HFNO or NIV, then the next step is ventilation. What is that protocol which we follow for ventilation? There is an Archnet protocol. What is that lung protective strategy called in ARDS?
Low tidal volume with
it is a name. It is lung protective ventilation. That is a strategy that we follow. So in lung protective ventilation, what is the first thing? First thing that you do, this is a volume cycle ventilation, no? So what is the first thing to do so in lung protective ventilation, you are deciding what are the values to be put. So what is the first thing to do? Tidal volume. In order to calculate tidal volume, what to do? You have to calculate body weight. Ideal body weight has to be calculated. How to calculate? There's a formula.
In case of male, it is 50 plus 2.91 into height.
2.3 into height in inches minus 60. In case of females?
Females for 45.5 plus 2.3 height in inches minus 60.
So with this you can calculate the ideal body weight. Only with ideal body weight you calculate the tidal volume, not the patient's actual body weight. And after calculating ideal body weight, then you calculate tidal volume. So what is the tidal volume that we keep?
4 to 6 ml per kg.
Initially 8 ml per kg, then we reduce the tidal volume 1 ml per kg. You keep on reducing till it reaches 6 ml per kg. This is sufficient enough to keep the alveoli inflated, and overinflation will cause ventilator associated lung injury. So we keep a low tidal volume. After tidal volume, what is the next thing? There is a tidal volume, then you have to, respiratory rate has to be kept. What is the respiratory rate? There is an FiO2 that has to be kept. What is the ideal FiO2 to maintain? All these things there is no fixed value that it has to be this. FiO2 has to be maintained in such a way that patient has a saturation which is adequate. That doesn't mean you put an FiO2 of 80, still the patient is maintaining. You can reduce it and see if the saturation is falling or not. So there is no strict value according to Archnet protocol. You manipulate it in order to achieve a proper saturation. Respiratory rates also, you can go up to 35, not more than 35. Up to 35 in order to maintain a proper saturation. What about PEEP? ARDS normally we say low tidal volume, high PEEP. This is something that we follow. So what is actually PEEP that is needed in an ARDS patient?
5.
It was earlier thought of as high PEEP. Why? Because it will drain the fluid from that. But now there are trials which states that you don't have a particular PEEP. It is optimum PEEP. You just need that pressure in order to drive. If the patient is having a PEEP of less than 5 also, this and the final prognosis or everything remains the same. That are all trials. So it is not minimum PEEP, it is optimum PEEP that is needed to maintain a driving force. So after PEEP, then there are two things. One is P plateau and the other is pH. These are the two things that have to be looked on. How much P plateau has to be maintained?
30 cent.
Less than 30, it can't be more than 30. So suppose if the patient you put on ventilator, patient is having a P plateau of more than 30, what will you do?
Try to increase the tidal.
Decrease the tidal volume. Already the pressure is high. If you increase again, it will be more. So you have to decrease the tidal volume and decrease up to what? Till 4 ml per kg. You can decrease 1 ml per kg tidal volume till it reaches a 4 ml per kg. What if in the reverse scenario? Patient is having a P plateau of less than 25. What to do? You increase the tidal volume. So you may have to maintain the P plateau. Then what about pH? pH has to be 7.3 to 7.45 is a normal pH, no? So if the patient is having a low pH, say patient is having an acidosis pH of 7.1, 7.3, less than 7.35, what to do? What is something that we can do? Why is patient having a respiratory, I already said acidosis is because of the respiratory component. So you have to increase the respiratory rate. But you should not cross more than 35 also. So that is one thing. And if in case the pH is very low, you have to increase the respiratory rate. Sometimes that is not sufficient also. So you have to increase the tidal volume. So all these has to be, that protocol is like that so that we maintain a very lung protective ventilation. So that is the Archnet protocol. There are two parts of Archnet. One is the ventilator setup. Second is weaning. So what is weaning? When to give spontaneous breathing trial in a patient of ARDS?
When their FiO2 is less than 0.40 and PP is less than 8 centimeter of
with the PEEP less than 8, if the patient is having an FiO2 of less than 0.4 or
and patient has acceptable breathing efforts.
No, or if the FiO2 is less than 0.5 with a PEEP of less than 10. In this scenario, this is one. Second thing, patient is itself taking spontaneous breathing effort he is taking. Third, if the patient is having a PEEP and an FiO2 value which is less than the preceding day. And then a patient should not be on this continuous dose of NMBA, muscle relaxants and all are not advised. So patient should not be on any muscle relaxants and patient should maintain a systolic blood pressure of more than 90 without any inotrope support. If all this scenario is kept, then you can give a spontaneous breathing trial. So these are the things in Archnet protocol. So this is the ventilation part. What are the other things to do in an ARDS patient? We have to hemodynamically manage the patient, no? So what are the things? How much fluid we should give? If the patient is having blood pressure, low BP, what to do? Low BP anyway will start on inotropes. What about fluids? Is there anything like only this much fluid has to be given?
Conservative fluid management.
Initial first 24 to 48 hours is proper fluid resuscitation. After that 48 hours, you try to keep the patient in negative balance. Basically, you need to drain out the fluid. So you have to keep a negative balance. That is the fluid thing. If the patient is having an infection, we have to give antibiotics. Diuretics has to be added. These and all comes in hemodynamic support. Have you heard about awake proning in patients? We do it in patients with ARDS. What is awake proning? What is prone ventilation?
Keeping the patient in
Prone.
position
So how does it help a patient with ARDS?
to recruit the airway.
All the posterior airways will be open. Major airways, ventilation space are in the posterior area. You make the patient prone, all these areas will be open up, alveoli will recruit more. So what is the time that you give for a patient? And you can't fully keep the patient prone, no? So what is the time? There is a time like 7 to 14 hours you give in a day. You give that trial. You make the patient lie prone with the face turned to one side, arms are parallel to the trunk, and you give us one trial. When do you stop this? You can't, there is a thing that you have to stop this awake prone ventilation, no? When the PF ratio is more than 200 or more than 300 it comes, then you stop the awake prone trial. What is the name of the trial? There is a very famous trial which that trial only we started giving importance to prone. Prosiva trial. The very famous trial, very long back it was there. So, is there any role of steroids in ARDS? If yes, when? When should we give steroids in ARDS? Steroids has to be given, but only in the first 14 days. After 14 days of ARDS, you give steroids, it will cause harm more than benefit. You give methylprednisolone, 1 mg per kg you can give for 30 minutes. After that, for next 14 days, you give 1 mg per kg per day. That you have to give for 14 days and then taper and stop. But this is all we do in an initial phase of ARDS, not late. So that is over with the ventilation part. We discussed the hemodynamic part. There is one more thing. If the patient is refractory to all these things, nothing is working, then what is the last thing that you do? ECMO. ECMO you do. In which patients you put on ECMO? There is another trial for that. It is called Eolia trial. In Eolia trial, if the patient is having refractory hypoxemia, irrespective of patient in ventilator and lung protective ventilation, you put the patient on ECMO. There are few criteria also, I think, that if the PF ratio you calculate, it is less than 50 for more than 3 hours, or if it is less than 80 for more than 6 hours, or if the patient is, I think the pH is less than 7.251, PCO2 is sustained more than 60 or 70 millimeter mercury even after 6 hours. All these patients has to be taken up for ECMO. So basically this is the line of management of ARDS where you protect the lung, you protect the hemodynamic parameters, you give steroids, you position the patient on and off, and meanwhile you have to correct what is the exact cause of ARDS. So that is the management of ARDS. In this patient, what did we do?
We started the patient on an IV and
did we intubate the patient?
No, didn't.
We didn't intubate.
Just
okay.
Okay.